Thank you everyone for joining this evening. I'd like to introduce our presenter. We are so fortunate to have Dr. Stephen Riggs, an associate professor within the Division of Urology at the Levine Cancer Institute. Thank you, Dr. Riggs, for being here. I'm going to go ahead and turn it over to you.
Yeah, thank you so much. Remains and continues to be a privilege to work with the prostate conditions at Education Council, and I appreciate the opportunity to talk about prostate cancer detection and more specifically focus our talk down around high-risk men. So with that, we'll get started. This is going to be some general information and some takeaways really around the prostate and the anatomy. I find it beneficial, and I think patients do when we talk about where the prostate is and its function. And so specifically on the screen, you can see that the prostate lives in front of the bladder. And so you urinate through this channel called the urethra, and that channel follows all the way out through the penis into where you urinate or void urine into the outside world. Now, the prostate is what we call an accessory sex gland. It produces some of the fluid along with the seminal vesicle when a man has an ejaculation. And you can appreciate its location to, and I should say proximity to the rectum. So when we're checking a man's prostate, we can feel the bottom half of the prostate by doing what's called a digital rectal examination into the rectum. And also, I think you can appreciate that currently the main way we get biopsies of the prostate is called transrectal ultrasound, or TRUS. And we put that probe into the rectum and then we look over to the prostate. So a little bit more about prostate cancer, kind of basic facts. 1 out of every 9 men will be basically diagnosed with prostate cancer in their lifetime. And then we understand that race has an important, plays an important role in the diagnosis of prostate cancer, with African-American men having the highest incident rates in the world. And they also have a mortality rate that is more than twice as high as other racial groups. We talk about a very favorable outcome when we detect prostate cancer at an early age, at an early staging. And then that survival tends to drop as you get more advanced staging. And that's where we do talk about the benefits of screening for prostate cancer. We'll talk a little bit more during this presentation about the role of PSA and how to think about it. But PSA came out in the late 80s. And since that time, we've definitely seen a reduction in the mortality or death of prostate cancer. So prostate cancer is very common, especially when you think about men. It is the most common cancer diagnosed in men. It's greater than that of lung and colon. You can see it makes up about 20 to 21% of the total cancers diagnosed in men. And then when you look at the death of prostate cancer, it's second to lung. So what you have is this dichotomy of a lot of people being diagnosed, but not as many deaths. So that just makes you appreciate that there's almost 2 different forms of prostate cancer. One that tends to be a little bit more lethal or has a higher risk of causing a man death, and then another where it's very treatable and hopefully found early, and where people can be easily cured with treatment. So what are the symptoms? Well, that's a challenging question. Patients tend to ask this quite often, because more likely than not, when you talk about screening for prostate cancer and you talk about thinking about do or do I not have prostate cancer, you're not really talking about symptoms. Most people's prostate cancer in 2021, in the last 10 to 15 years, is being diagnosed by blood test, PSA. But people with more advanced prostate cancer may have these symptoms, and that can include trouble urinating. If you remember from the diagram on the initial slide, you urinate through the prostate. So if you had a lot of prostate cancer, it could squeeze that channel down where you wouldn't be able to urinate. You can have some urine or blood in the urine or in the semen. You could have erectile dysfunction. And then if prostate cancer spreads outside, you could have a pain in the bones, because prostate cancer does like to spread outside to the bones in more advanced stage. And then really this last bullet is more advanced prostate cancer. And that's if you got into the spinal column, you could have impingement or growth into pushing onto the spinal column. And then this could create symptoms such as numbness in the legs or feet, or even loss of some of your bodily functions. Now, I think it's really important to remember, and it does note it at the bottom of the slide, that more likely than not, these symptoms are going to be caused by other things than prostate cancer. So what are the risk factors? I really like this slide because I think it starts to pare down our strategies in screening and how we think about that in 2021. And we're going to keep kind of working into that through this presentation. But age is a risk factor for prostate cancer. The older you are, the more likely you may be diagnosed with prostate cancer. Race, we mentioned this before, and I'll mention this several times, is a big risk factor for prostate cancer, especially when you talk about African Americans. And then counter to that, it's much lower risk and when you talk about those of Hispanic descent and or Asian descent. Geography, so where you live plays a role, and then family history. So this is where we talk in genetics. So risk is much higher in men with first-degree relatives. So that would be a brother or a father or a mother diagnosed with prostate cancer at an early age, especially if that prostate cancer is of what's considered higher risk. And those with a history of breast cancer. So these are big things. We talk about breast cancer, ovarian cancer, pancreatic cancer, colorectal cancer. And what we're really looking for is what we call germline mutations or inherited genes. And then these may be things that allow the prostate cancer to grow, promote itself, and to be of a worse variety. And then I think it's important to remember there's other risk factors, more environmental. So what kind of diet, your lifestyle, obesity, smoking, your occupational exposure, and then if in some instances, inflammation of the prostate. So let's talk a little bit more about PSA. So it's important to remember that PSA stands for prostate-specific antigen, and I find this to be a challenge because it's not prostate cancer specific, it's specific to the prostate, and thus there are a lot of causes of someone's PSA being out of the normal or elevated and not due to prostate cancer. So that makes it a challenge to use PSA as the only screening methodology for determining whether one has prostate cancer or their risk for prostate cancer. And I would tell you, we've historically used a level of greater than 4 of concern, but we've gotten a lot smarter over the last couple of years. And it's certainly allowed us to think about age-adjusted PSA, and then also understanding over time what the changes in one's PSA to help predict better, to understand better. We talked about the digital rectal examination and the fact that if you were to put your finger in the rectum to perform a digital rectal examination, that you'd feel the bottom part of the prostate, and you can understand and appreciate some limitations with that. And then on the far right really gets into the space of after we've decided that I'm concerned or concerned enough to pursue a further evaluation. The most common evaluation is to proceed with a prostate biopsy, and that's often done with transrectal ultrasound. And again, that probe goes in the rectum, it looks over to the prostate. And we do what's called a systematic prostate biopsy, and usually that initial biopsy is what we call 12 cores, or we take 12 samples, and we do that from 6 different quadrants. So we take the prostate and we break it up into a right and left, and on both of those sides we break it up into 3 quadrants, a front, a middle, and a back, and then we take from 2 each. So that will give you 12. There's a role for MRI and an evolving role. So you may hear that from your physician. There is an evolving role of genetic markers to help kind of understand your risk or for prostate cancer, and thus your desire for a prostate biopsy or not. And then when you talk about Gleason grading and grade grouping, these are things that when you do have prostate cancer that you will hear about. So I did mention this before. So PSA was first proposed as a marker in the 1980s. And these were 2 landmark studies around this. And we've been, we really came out of the 80s and the 90s with an aggressive screening using PSA quite frequently and quite common. And we've learned over time that we believe screening is the right thing to do. It's just maybe our strategies were a little nearsighted, and we needed to think a little bit more broadly and better about how to better screen and screen more intentionally and optimize that screening. This is just highlights really across three big studies. One in the United States, that's in the middle, and so they did PSA screening along with lung, colorectal, and ovarian screening. A Swedish trial in the far right, and then what we call a European randomized study of screening for prostate cancer. And what I think all of them show is a consistent trend of reducing mortality by screening. Although what they don't show is specifically how to screen, and that remains kind of the controversy and what we're going to get into a little bit further into this presentation. So again, prostate cancer death, if you look across this axis, it appears to be decreasing around this 1990 when this PSA became quite frequent and quite commonly done in the United States for patients. And then in the 2010, and that range has started to come under a little bit of questioning. And so there's not been as much PSA screening since 2010. And so there's a question of whether that's been the right thing to do or not. So how we think about PSA is really not just by your absolute value. So remember before, there's a lot of literature, or there will be a lot of information that permeates around testing for PSA for people with a PSA over 4. But again, we spoke a little bit that we think we've gotten smarter in this area. And so we understand that earlier PSA may be an advantage for multiple reasons, one of which it may serve as a foundation to personalized detection strategies. And so for people younger in their mid 40s to even early 40s, we do think about screening PSA earlier, especially if you have certain risks, like we talked about before, being African American or having a family history. And then you get older, we start thinking about, hey, do you have a significant life expectancy? So for example, if you're 85 years old and you don't have a long life in front of you from natural causes, we'd be less inclined to screen that type of patient. And really probably the most common bucket of people, general population, if you don't have any risk, is in the 55 to 69-year-old. And so once we kind of understand what age you are and your risk, and then we talk about average PSAs for that age group. And then so we can start working backwards from that and understanding that, hey, if you get a PSA early and say you're 55 or 60 and your PSA is less than 1, well, we may certainly suggest that you can screen less frequently. That doesn't mean we'll never screen you again, but we can start stratifying you. And then if you have a higher PSA than what we would expect for your age, and if you do or do not have risk factors, we can set out a screening program tailored to you once we have a fruitful discussion about where you sit, your life goals, and certainly your risk factors or lack thereof. And then at the bottom here just talks about baseline PSA. And again, does that PSA indicate further action? And now what we started is working more upstream and suggesting that instead of always PSA to biopsy, sometimes it is PSA to a certain rate of PSA check. So that may be a shorter interval to, hey, I'm worried about your PSA. Let's do a different test besides the biopsy to help understand your risk further. And that may be a biomarker or an MRI. So we started to interject this stage or this process in front of going directly to a prostate biopsy. So men with a PSA greater than 2 should have ongoing screening. This is something that we talk about quite a bit. And then I would say we even think about that a little bit deeper. Again, if you are very young, 45, your PSA should be much lower. An average PSA for a man in the 45 is probably in the 0.5 to 0.7 range. So we would think about what your PSA means for that age and based on, again, your race and family history. And then on the other end of the spectrum, if you're 75, your PSA is less than 3, that would be highly unlikely that you would end up developing prostate cancer that would be life-threatening. So again, we just want to be thoughtful about that and engaging with patients on how to think about that. And then this rescreening interval is based on age and PSA level, like we talked about. And so just kind of understanding over time how to screen. So being thoughtful in our screening, not just one size fits all model. That's probably what I would leave most with you to remember. So this is from the SEER data set. This is the SEER is run by the National Cancer Institute and basically encompasses almost 50% of the total population. And so what I take away from this, and what hopefully you'll take away, is that the incidence of prostate cancer is much higher at an earlier point in life in African American versus white. And then the mortality is equally, if not more significant in these populations, greater in Black than in white. And you can see that that follows suit all the way down the line. So this is where we really start to frame talking about screening African American men in their 40 to 45 range, or around 45, just because of what we're talking on this slide right here. So what about disparities? This is probably my favorite slide. Healthcare access. I often will communicate to people that although your genetic code is very, very important, your zip code may be most important. So your access to care, the environment you live in, the resources that you have. And if you add that plus some patient biases and some physician biases in disease management, plus this environmental and I should say genetic component or intrinsic disease biology, meaning your makeup of the cancer, the makeup of your body, that can lead to increased mortality or increased death in prostate cancer. So that's really what we're trying to be thoughtful about here. And I think starts to speak to why we don't want to look at everybody the same who walks in and wants to be screened. We need to be thoughtful and engaging and think of all these things: environment, again, your risk factor, all the questions that we need to be asking, and then your life goals and how you look at it and your understanding to help you make a decision about screening and or not. And then when we screen, what to do with it. So we've mentioned this before, but just to highlight this again, probably can't be said enough. What are disparities in prostate cancer for Black men? We talked about earlier onset. So we talked about screening in your 40s because you're African American. We talked about increased aggressiveness, and that just biologically they appear to be more aggressive. And then that leads to, if you don't screen earlier for African American men and they have more aggressive disease, then what that results is in having more metastasis at presentation. And what do we mean by that? Is that means that the cancer leaves the prostate and it's cracked the prostate and it's spread outside to other parts of the body. So when we think about personalizing prostate cancer, there's multiple ways to think about this. We'll talk about some genetic testing in a second, but just to start off with MRI, they're quite frequently used now, at least in the United States, and especially in Europe. And it really helps us understand the extent of prostate cancer if you have it. And it's really trying to understand, is it only in the prostate or is it outside the prostate? And then probably even more importantly, or more commonly used for people that are diagnosed with prostate cancer, to try to help them understand a risk. So MRIs are very good at seeing Gleason score 7, 8, 9, and 10 prostate cancer. It's not very good at seeing what we call Gleason score 6 or grade group 1. And so sometimes people will be, or oftentimes people will have what we call favorable prostate cancer. So that's grade group 1 or Gleason score 6. And we'll talk about active surveillance, but we'll also perform an MRI, because if the MRI is, quote, negative, that would be in line with the Gleason score that we perceive that patient or that individual to have, because it doesn't see the Gleason 6 well. It only really sees the 7, 8, 9, and 10. And so if you saw something on MRI and you thought you had Gleason 6 or grade group 1, then that would be a disconnect, because what that would be suggesting to you is there actually may be more to the story. Genomic tests provide more information, both before even thinking about a prostate biopsy, or if you have prostate cancer, to try to understand risk. And then saturation biopsies really just means taking more prostate biopsies. So for example, if somebody had a elevated PSA and they had a biopsy that was negative and that PSA continued to go up, one strategy may be to say, hey, maybe I missed it the first time and I'm going to go back and take more biopsies, sample different areas, try to reduce my error rate. So again, we touched a little bit about this, but just a little bit more. So genomic testing to help improve the stratification and performance of PSA. So starting with PSA and then moving to using a genomic test or considering this to help people make decisions. And what these do is help people, both physicians and patients, really understand disease risk or risk of disease, and thus avoid biopsies and really enrich those patients who we actually should be biopsying. So to improve our screening practices. And so enhance risk stratification of newly diagnosed prostate cancer as well. We talked about this. So that, helping people to confirm who are best suited for surveillance or interventional therapy. I always kind of frame this as thinking about prostate cancer as either a sheep or a tiger wrapped in sheep's wool. Oftentimes you think it's a sheep, and so what you're doing with genomic testing and or MRIs is trying to confirm that it really is a sheep and not a tiger wrapped in sheep's wool. And then further down the line, for advanced cancer patients, doing genomic testing, really either a germline, which is how you're made. It's basically your body's makeup versus genetic testing, specifically the cancer. So those are two different ways to look at it. And they're emerging therapies, continue to be emerging therapies that may target specific genetic pathways. So this tries to summate all of that in one slide. What I would take away from this is the type of prostate marker that you're using would depend on kind of the space you're in. So on the far left, if you're talking about, hey, do I have prostate cancer or not? You're talking about PSA, prostate health index, 4K score. A lot of these in SelectMD X are trying to help you decide and help the providers decide, do you meet a risk criteria that makes each of you or both of you uncomfortable, and therefore do you want to proceed to a prostate biopsy, or do you want to proceed to a different genetic test, or do you want to proceed to an MRI? And then knowing who to biopsy and rebiopsy, so that's kind of the purple area right there, that's PCA3, no error and confirmed MDX. And then who to treat. And so again, for example, if you were diagnosed with prostate cancer and we were recommending active surveillance, Oncotype DX and Prolaris, or genetic markers that can help you decide on or further your understanding of the risk of the actual prostate cancer you have beyond traditional measures such as PSA and Gleason score. And then as you move down the line, hey, I may have had my prostate out, but I want to further understand the benefit to, say, getting radiation down the line. And so using Decipher tests based on the cancer that was removed at the time of surgery, it may help in that area. And so again, the context is really important. And then I would tell you, kind of the easiest thing to remember is if you have primary treatment for prostate cancer, the PSA is actually a very good marker at that point, because think about it. If you have your prostate removed, you should not have any PSA level. So it's a comforting measure if your PSA is undetectable after your prostate cancer is removed, to know that there's no cancer remaining. It's an easy way to follow. And really the same thing's true for radiation. You should have a really low PSA level, and it should stay low after radiation. And then you can see a couple of the other things below. So what about staging? So with really any solid cancer, which is what solid tumor, which is what prostate cancer is, you get a tumor stage, a node stage, and a M or metastasis stage. So the tumor stage is really refers to what's going on in the prostate, and that is based on clinical factors. So as you can see right here, and some of it's imaging as well, but hey, if the tumor's only in the prostate, and you can only feel it in the prostate and you don't feel it going beyond, then that would basically be a T1. So that would be somebody you have to do a prostate biopsy, you have to diagnose a prostate cancer, and you're putting all this together. And then really the only way to know the nodal staging would be to do some type of imaging, usually a CT scan or an MRI. And then metastasis would be the same thing based on imaging, either a bone scan and a CT scan, or one of the emerging and kind of more mainstream now imaging, looking at PET scans, excuse me. And there's newer specific radio tracers for PET scans. So traditional PET scans are actually not used for prostate cancer, but there's emerging and now commercially available PET scans that are more specific, because the radio tracer, what they put in your bloodstream, is more specific to be more sensitive and specific to prostate cancer. Now, I will tell you the staging is a little bit, so the tumor staging is pretty black and white here, and you can talk to your physician about this. And then you go to stage like a grouping, stage 1, stage 2, stage 3. So you take the T, you take the N, you take the M, you actually take the PSA level and the score of the cancer, and that gets you a staging. So if you're asking about the staging, you'll need to understand that and get that information from your doctor to add that all in, and then align the stage with actually what the risk is for your particular disease. You hear a lot about Gleason score. We mentioned this before, but really Gleason score is really only applicable in 3, 4, or 5 range. And really what this is that, hey, if you were, for example, a Gleason 1, that would be, that would look very much like the normal prostate. And then as you get further away from where the prostate looks normal, it becomes very disorganized. And you can see that that is what you would call Gleason score 5. Excuse me. And then you normally, right now you'll hear a lot around grade grouping. And so basically what that is if you're Gleason score 6, so traditionally we talked about Gleason score. So if you're Gleason score 6, you would almost always be a Gleason score 3+3. And then you could be a Gleason score 7, and you could be either a 3+4 or 4+3. Now, we came up with grade grouping to remove a little bit of the 7 conundrum. So if you're grade group 1, you're a Gleason 6. If you're grade group 2, you're a 7, but that first number is a 3. And if you're a grade group 3, you'd be a 7, but the first number would be 4. So we did that because we understand that Gleason 7 really behaves differently if you're a 3+4, or if your first number is a 4 and you're 4+3. So just be cognizant, aware of that, and make sure you're asked questions around that with your provider. So what about imaging and scans? We talked a little bit about this before, excuse me, about doing transrectal ultrasound and biopsy. That's probably the most conventional way to do a biopsy, and that's where you put the probe in the rectum. And again, the prostate is sitting right up against the rectum. I will tell you there's a fair amount of data and discussion coming on a perineal biopsy, and really that discussion and opportunity comes around reducing infection, because when you come in through the rectum, you have to pierce or put the needle through the rectal wall, and you can risk contamination. And so that's one of the risks of the prostate biopsy. So there is some push to do what we call perineal biopsy. And you may hear more of that about that emerging in the mainstream news over the next couple of years. And then CT scan, that's for staging. That doesn't look great at the prostate. MRIs look better actually inside the prostate, but CT scans are really to look outside the prostate, to look at the bones and to look at the nodal status, to give you that T and an M staging like we talked about. MRI is becoming a big and looking both at the prostate and also the lymph node status and the pelvis. And then we mentioned prostate, excuse me, what we call PET scans. And the Aximum PET, or fluciclovine, is a FDA approved scan that is specific to prostate cancer. And the same thing, the PSMA scan is picking up a lot of steam and interest. And again, these are just an improvement in prior staging. We've understood for a while that CT and bone scan are not perfect staging. And so these are efforts to improve staging with prostate cancer. And then another traditional scanning is bone scan. So very traditional staging for prostate cancer for people with more advanced prostate cancer. And what I mean by that is higher PSA, Gleason score 8, 9, or 10 as bone scan and CT scan. So that's how, again, we will figure out your clinical stage by doing imaging. So genetic testing, about 10 to 15% of prostate cancers are actually hereditary. And there's several abnormal genes are linked to increased risk of prostate cancer. And understanding this impacts our screening requirements and really how we think about it. And so that's why these questions up front, specifically when people are even considering screening of prostate cancer, and hey, what age do I start screening? Like we talked about, if we thought starting in your 40s was right, we would be asking about first degree analysis with prostate cancer, your breast cancer, your ovarian cancer, your pancreatic, your colon cancer. And we understand that, and we know now that 2 breast cancer genes, BRCA1 and 2, are the most commonly found mutations in people with prostate cancer. So it's not just breast anymore. So genetic testing is important. We really think about this. So again, we talked about in screening or thinking about this if you're going to consider screening for prostate cancer. And then what if you're diagnosed with prostate cancer? We want to keep working backwards and thinking about what that means. So people with really high risk prostate cancer, especially if they're young, and more advanced prostate cancer. So that's what the next 2 bullets are talking about: advanced or metastatic disease, meaning if it's spread outside the prostate. And then the other things, hey, is your mother, father, brother, sister, first degree relative been diagnosed with any of these other cancers where it might suggest what we call a germline mutation, or something that's passed on by hereditary means that might make you an increased risk to have aggressive prostate cancer. Lynch syndrome is basically a syndrome where one of the findings is colorectal cancer. And so if you have BRCA1 or BCR2 mutations, these are found, can be found on profiling, taking the tumor and looking at that. I've looked at this pretty well. And this is actually a really good website to help you think about this, because this can get confusing, along with prostateconditions.org. Just to be thoughtful and keep reiterating some of this, and it does pare down a lot of these topics into smaller, bite-sized areas that you can watch and think about, because it does get confusing. So in summary, I hope I left you with the concept that PSA screening it's not a one-size-fits-all model. It's not something that we should just do for everybody, irregardless of race or environmental status. We should be thoughtful about this, and we should engage individuals. So understanding the risk and benefits of screening is important. And only men who benefit should be screened. And that's easiest to understand that, hey, if you're, again, much older, if you're 85 years old and you have a life expectancy of 3 years, you wouldn't benefit from screening. We want to take advantage of markers, both genomic and genetic testing, to help enrich our understanding of your disease if you are diagnosed with prostate cancer, and also help understand your risk for disease if you have not been diagnosed. We always want to remember that not all prostate cancer needs to be treated. And we talk about that in terms of active surveillance and using genomic testing or using imaging to help understand if you're truly the sheep, or making sure you're not the sheep or the tiger wrapped in sheep's wool. And we want to give you confidence, and your provider confidence, that you're doing the right thing. And that's really important to understand. And please remember, African Americans and those men with a family history of certain cancers, of those with genetic mutations, should really start screening early in their 40s, and being thoughtful and being your own advocate for yourself, and understanding that is really important. So with that, I will end on this slide. Thank you.